and most probably this is my last talk of the web series. When we have designed the workshop, then I'm thinking why there should not be any radiology lecture. So that's then we have one more radiology session by Shivani. It's a general overview. I'm not going details of the radiology and mostly on CT. But before going CT, we should not forget the X-rays, the classical X-ray, which we mostly in common OPD practice we prefer for the enlarged adenoid, the X-ray nasopharynx in case of the OSA or the nasal obstruction. And as today has a very good session on foreign body by Counselor, and these are another most commonly prescribed X-rays for foreign body. And though infection is nowadays less, but still we can get and we can have to perform this kind of assay where we can find like in case of a retropharyngeal abscess, we may get widening of retropharyngeal space. In case of acute epiglottis, we may have the classical trumping sign. Also, in case of a groove, we can get a stable sign. These are classical classroom teaching for us. And from the area perspective, I want to share two X-rays here. One is X-ray lateral view of neck for a tracheostomy child and for the decannulation issue. If you can appreciate in this X-ray also, it doesn't require a very heavily high resolution CT or MD-CT, and you can appreciate what is it on his airway. And this is the position we can appreciate that he has a collapse. That's means suprastomal collapse here. And another X-ray I always like to quote refer. This is the X-ray I have learned from this X-ray from Sanjay Sachdeva from Delhi. That I have asked him. So how will you radiologically we know that we can decannulate or you can remove T2? So he said to me, so you do simply X-ray soft tissue neck lateral view and have a look if there is any airframe between the soft tissue and the stent and or Montgomery tube, and if it is a free, then you can easily remove. But if you can see here, there's enough soft tissue which is hugging the Montgomery tube, so it's not ideal to remove. But if you can appreciate, there's a endoscopically we can see the superior end, we can see the lower end, but it's very difficult to see the that means middle portion where it hugs the Montgomery tube. So that's a simple X-ray can say we can remove the tube or not. So MD-CT versus SRCT. For CES, I always thought that it was a SRCT, and I not got that much of technicals between MD-CT or SRCT. Basically, MD-CT is a raw image, and SRCT is a software, or you can nowadays these machines are mostly go with the MD-CT, and they can format the SRCT things. And SRCT is specifically for interstitial or parenchymal lung disease, and MD-CT for very good. As a whole, the whole raw image is given by the MD-CT. And we can, with the help of and software, we can go for 3-dimensional, 2-dimensional, all this thing. So basically, MD-CT is for central array, is the primary imaging modality for the central array. Current generation scanner provides very high spatial resolution image in a very quick time. That's the most important in case of a children, because they're mostly in a particularly in a distress child, it required we generally get very less time, and most of these times required sedation. That's the experience of the center is very much essential. We need a very good pediatric anesthesiologist in the center. Also, it's very difficult for the intubated child, days child. I'm not telling about the month child, or sometimes it's required. I'll go to share one case today. And that patient who was intubated already, and we have shifted from NICU to the center where we required a radiological evaluation, where we need a very quick CT evaluation. And as I mentioned, it can reformat everything, 2D, 3D, everything. And it's basically very advantageous for a central array in perspective for an airway stenosis, any kind of new tumor or complex congenital airway disorder. but it also airway is a physiology, so we need a dynamic study. So in case of tracheomalacia, this scan can also give a idea, a dynamic study, but it's very difficult in case of children. This is how the 2D images in a MDCT, the full airway can appreciate from the glottic to the tracheal link, bronchus, and primary and secondary bronchus. And this is how we can reformat that 3D. In a 3D is very interesting. I'll try to demonstrate if I can. If I can, I don't know. Whatever you require. You require parenchyma, you will take the parenchyma. If required angio, you take the angio. If you require soft tissue, you can take the soft tissue. That way, we can reconstruct the 3D images. Next, trachea. As you know, child trachea is almost C-shaped, and this is a long-standing COPD cases where you get discouraged trachea. And it basically, as I said, that it is very good for the central area and mostly the pathogenesis of the subglottic stenosis. Here you can know the two-dimensional stenosis. Also, how many log segment it is involving. So here you can appreciate almost there's a 3 millimeter of the segment is involved. And this is how we can appreciate tracheomalacia. It's a physiological and dynamic study, but again, I'm saying it's very difficult because it's very difficult to give the command to the child, and it's basically done in a full. This is a full inspiration that the whole lumen is widened, and if in a full expiration, if you can take, that's why the MDCT they can very seconds in a seconds they can whole volume of data. That is the beauty of the MDCT, and if the full expression, if it cross more than 50% of the lumen, then it has a tracheomalacia. So similarly, in a complex congenital anomaly like right aortic arc, the secondary, this is one of the causes of secondary tracheomalacia or shifting of the trachea, and left subclavian artery. This may also we can appreciate in CT. Foreign body bronchus, this is basically more important in case of radiolucence, which plastic foreign body, and also the oral foreign body. And contrast is required sometimes if you have a mass in the mediastinum, and also sometimes we can go for the any aberrant vessels, like in a aortic arc, which give a secondary tracheomalacia. But if you see this CT, don't believe this CT. It is a 1-year-old child with a respiratory distress not due to this mass. It's basically thymus. So this thymus is not causing any kind of respiratory distress of this child. And interestingly, we did the adenidectomy of this child, and this child gets well of his respiratory distress. Congenital neck mass. This is my last case. So if you can appreciate, we have performed a CT on the 5th day of his life, where we did the bronchoscopy, but afterward he has a distress and he is not maintaining situation. Then luckily our pediatrician has intubated the child in a very difficult situation, and we have when we perform CT, we did the bronchoscopy, but bronchoscopy there's a lots of difficulty. Every time a bronchoscope gets stuck and it deviated towards the one side, and we are not getting the idea of what happened with the cell. And we are trying with the disease also. That time we have not the idea that 5 days old child has a death mass of glottic shift, because we have no that mass of experience. Then we have sent the child with a tube for radiological evaluation. Then we have found this mass of neck mass. But antenatally, it was a random case in our hospital. Actually, we have no pre of ultrasound and of the patient. And generally, this kind of mass we should diagnose antenatally. And we have found that this mass was there, which is obscuring the airway, pushing the trachea almost to the contralateral side. And if you can appreciate the extension up to the nasopharynx, from the nasopharynx up to the suprasternal area. So this is the mass, and this is the right student patient, and we have accessed the mass on the most probably 10 days, and baby gets well. So we can extubate the child after 48 hours. So that's how sometimes in a very early neonate radiology, but it's very challenging to put the baby on radiology center, radiology cube. And that's why the antenatal history, antenatal radiology is very much important to know that what the anatomy God will be going to give to the child. This is how, if we can see the large snake and the cystic lesions by our fetal medicine, but we have not, the parents are not convinced. Somebody else tells he has a large tumor, so don't go for, and they have abort the child in under a hospital. So, but definitely we are waiting for to do exit, and we are preparing for that, but we are not give the delivery of the child. So in conclusion, it is always a complementary to a bronchoscopy. It is a mostly important for the extraluminal pathology. Real-time CT can help in bronchoscopic biopsy, and very important to follow up for a pediatric radiation. So we should have to follow the guidelines provided, and so they should not be too much. And 3D reconstruction and partial bronchoscopy, everything we can do from MTCT. So last, I want try to share one case in software. This is a DICOM software. So basically, it's very important to see the brain of the child also. So there may be any neurological deficit. And if you go down, 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 then you can appreciate the PNS area. And going down. Then VFS. Then glottic. So there's a little bit one vocal cord is medialized, pyramidal position, and this is a trachea, and this is the trachea. This is at the level of thyroid, and this is the tracheostomy in situ, and we can going down how much lower tracheal wall. There's an artifact somewhere, and this is how we can evaluate the whole lumen. And also we can go with the, if you require the other card also, this is how we can know that who is, if you, this is the midline. This is, you can see the midline of the airway. So we can have evaluate. There's a stenotic segment here. We can also measure the how much it's from the tracheostomy side, and also how much part of the stenotic segment. So also we can do, this is a 3D ampere, as this is how we can, as what is required here. This software has a very, if you go here, then there's a angio, airways, bone skin to whatever. I am interested for airway. If you see the airway of this child, then we can appreciate his airway. Then you can little bit turn. Then we can appreciate his. Then you can appreciate, this is the child most yesterday Kesave showed a video during his tracheal stenosis. So you can appreciate this is a tracheostomy. How beautifully this is, this 3D has all the air. The sinuses are filled with air, mastoid filled with air. This is the air column. This is the air column is coming, and this is the stenotic segment. So this is how we can take all these images and we can reconstruct wherever we require, what we have required. That's all from the city perspective. Thank you so much, sir.
Thank you, Vishwajit. I think we will finish off Deepa's paper and come to you, or we'll have the comments on your